Hey, this is Hasan. I'm from University of Virginia. So my talk hopefully will be about 25, 30 minutes, and it's just on evaluating pediatric neurosurgery patients.
Okay, all righty. Carry on.
Okay, so let's start. You're moderating, by the way, Greg.
All right. Doesn't really matter.
Okay. It's again a pleasure to invite all of you and to welcome you all over here. This is webinars that we've started in collaboration with the Pakistan Society of Neurosurgeons, World Spinal Column Society, WFNS Spine Committee, as well as World Federation of Neurological Society. So everybody is chipped in here. On Saturdays, we're doing webinars with IFNE and WFNS Endoscopy Committee this is about endoscopy only. Hasan Syed is a dear friend for some time. He's a pediatric neurosurgeon, and he's going to tell us something about how to evaluate a patient pediatric patient with neurosurgical problems. Okay, Hasan, it's all yours. You want to share your slides? Very much.
Yeah, I'm trying to share my screen. It just says that it's disabled right now.
Can you please enable Hasan to
You can share now,
slides?
yeah.
Okay.
Yes, sir.
Are you guys able to see that now?
Yep.
Great. Well, first of all, thank you, for inviting me. This is something that I find very interesting, and in terms of evaluating and seeing pediatric patients, I think it's one of the most rewarding things, in neurosurgery. And Dr. Saman had asked me to speak to some of the trainees and young neurosurgeons about tips and pearls for evaluating brain and spinal conditions in pediatric neurosurgery patients. And so I hope that you guys learn something, or at least review something for your clinical exams. So before I start, I just wanted to mention one thing. Some of my colleagues and I formed this global neurosurgery initiative. And it's something that we find very rewarding as well in terms of surgical teaching and education. There are 2 surveys and publications we put out. You can see Pakistan contributed a lot, and I'm sure a lot of the participants today also filled out the survey, so I wanted to personally thank you guys as well. So just talking a little bit about the objectives for today, I want to cover how to evaluate a child with a neurosurgery concern, including the things that we already know in terms of history, physical exam, and imaging studies if needed. And throughout the presentation, I'll talk about common cases that you might encounter. And mainly they focus on head shape, macrocephaly, and sacral dimples, and we'll finally conclude with some resources for the trainees. So I think we've all heard this before, that children are not little adults. They have specific pathology that are different from adults, but certainly the same skills that we learn in terms of evaluating all neurosurgical patients can be applied to children with some caveats. And so anytime we see a patient, we think about the relevant history, the physical exam, but particularly in children, the concept of observation is really key. And you can pick up a lot of information just with observation. After thinking about the problem, you have a list of differential diagnoses in your head, and that can result in ordering the imaging studies if needed, and then diagnosing the problem. So this concept of observation, I just wanted to talk briefly about. It's something that we use in everyday life, in medicine and in non-medical related issues. And observation leads to pattern recognition. And so I drew this diagram here, and all of us can probably fill what's supposed to be next. And similarly, when we're evaluating patients or thinking about what could be wrong, a lot of our experiences and the things that we think about subconsciously come out in order to assess a patient and to figure out what the diagnosis is. And so these patterns, can be seen or should be seen, in terms of identifying clinical and radiological concerns, and then understanding their implications in terms of neurosurgery. So I want to illustrate the concept of the observation in terms of pediatric patient evaluation with you with these three quick cases. This child was a 2-year-old who had midline pit, and it was very hard to see, but right here in the center, there is a nasal pit and some scratches from the child. But when seeing this patient in clinic, we asked about if there was any history of drainage or things like that. And so that led to, a differential diagnosis of all the things that could be midline nasal masses. And so this turned out to be a nasal dermoid cyst and stalk that you can see on the scan and the MRI that was ordered. And then it was surgically resected. What's critical for these types of cases is that a fibrous stalk can be present, which represents an intracranial connection. And that can be seen in probably about 15% of these patients. And so this surgery was done with our ENT colleagues, and this midline incision really healed very well. The next patient, similar story, a 4-year-old boy with a scalp lesion, you can see here without hair. This became painful to the child after some time. Again, we think about dermal sinus tracts. By assessing the child with imaging studies, we can see if there's any intracranial extension, and we can plan for a safe surgery. This third case was a 14-year-old boy with a pulsatile enlarging scalp mass, which turned out to be a cercoid or a scalp AVM, sort of on the rare side. But again, something that you could easily miss. Before cutting this child's hair, it's hard to tell. And so it's very important to talk to patients and even kids and ask them direct questions depending on their developmental history. And so this scalp AVM was fed by extracranial supply as well as from the left ophthalmic artery. It was embolized and then subsequently resected. Again, observation is critical in congenital anomalies as well. This is just some pictures of common things that we see in neurosurgery. So, I find pediatric neurosurgery extremely fun because of the variety of pathology. I have a mixed practice of adults and pediatrics, but I think, we can all relate when we see pediatric patients, they don't really complain unless there is a problem. And so there's a wide depth and breadth of pathology, including congenital anomalies, head shape, hydrocephalus, tumors, vascular issues, trauma, and other conditions as well. So in keeping with the theme of children are not little adults, it's important to note that they are a unique patient population. They all represent a distinct anatomy, developmental and physiological characteristics, and they can be really subdivided into age groups. And we'll talk about that a little more in terms of the examination. So just some basic pearls to help with your assessment. We already talked about how important it is to observe a child. It's also equally important to obtain a thorough developmental history. We have to know what are the normal developmental milestones in order to fully assess a child. It's important to also know about the primitive reflexes in newborns and infants. And then in terms of the assessment process, you have to be able to change your routine or adapt as well, depending on the child's behavior. Allowing a child to play as you observe it makes things easier. You may have to have some toys, in your white coat or in your clinic. When children can communicate, it's important to explain what you're doing so that they can feel comfortable. I always go into a room before the COVID crisis and just, give a high five to kids. And now a lot of our clinics are virtual. And so I end up giving virtual high fives just to engage kids a little more. So another pearl that we all know is, always speak to the parent and the caregiver for information. There are oftentimes the parents are the ones that sort of drive what the next steps are in care, and they know. And I find this especially important in terms of evaluating patients with hydrocephalus and shunt issues in the emergency room. It's also important to note that changes in vital signs in children as opposed to adults can often be a late sign of neurological deterioration, and that's why it's important to focus on other parts of the neurological exam. So looking at question number 1, A mother brings her daughter to her clinic for concerns of macrocephaly. As a pediatric neurosurgeon, you start assessing the infant's developmental milestones. She is able to sit independently without support. What age group is she? Does someone want to try answering this question?
Okay, if there are any takers, would you like to just raise your hands and we'll switch on your mic and you can answer? So
Rupesh wants to reply. Dr. Rupesh wants to.
Hello, so yes, the correct answer would be 6 months.
Yes, that is absolutely correct. So let's talk a little bit more about the neurological assessment. Developmental milestones are key, and I just want to pinpoint a couple key ones. 4 months of age, a child usually is able to turn towards a voice, sit supported with head control, and roll to supine. At 6 months, as we talked about, a child should be able to sit independently. And then by 18 months, they're usually up and walking as well. Again, this is all dependent on the gestational age. But in keeping with the assessment, you focus on the history in terms of the delivery, any issues in pregnancy, medical, social, and family history relevant to the chief complaint. And then the physical examination can also be tailored based on the age of the child. We typically do this in 2 to 3 phases: the neonate up to 1 month, the infant from 1 to 2 years, and then the older child as well. So examining the neonate, and that's the age less than 30 days, I want to just go over some of the reflexes that are important to know about. The rooting reflex, which is when we lightly stroke the cheek. This allows the child to turn the head towards the stimulus. It's usually present from birth to 3 months. You have the stepping reflex. When you hold an infant up in place, they're able to automatically quickly step in terms of a walking movement, and that's usually present from birth to 4 months. And then you have the Moreau reflex, which is symmetrical abduction and flexion of the upper extremities when dropping the head back, and that's present usually from birth to 6 months as well. This is a nice chart that is from the Principles and Practice of Pediatric Neurosurgery book, Albright's book. It goes through the neurological exam respective of the gestational age. The pupil response is key no matter what age there is. Usually a failure to blink to light may reflect an altered level of consciousness or even a structural lesion, so that's important to evaluate. Posture, there's usually a progression of tone in the upper extremities from extended in preterm infants to beginning to flex and then fully flexed at term. Moving on towards the neurological exam for the child and adolescent. As a child becomes older, you can adapt some of the same exam techniques that you would do for an adult patient. 2 things to note is that hand preference usually before the age of 2 is considered abnormal and should be worked up. And then in terms of cerebellar function, usually at age 8, a child can do more of the cerebellar coordination and tandem walk as well. So the next question, just to keep everyone engaged, all of the following may be signs of elevated ICPs in a pediatric patient except. Anyone want to try to take this question?
So people can answer in the chat, which is what they did the last time. All responses so far are D.
And that is absolutely correct.
Everybody.
It is a flat anterior fontanelle. So just briefly about assessing intracranial pressure in pediatric patients. For those infants who have an anterior fontanelle, and then those that are toddlers, usually macrocephaly is one of the indications that there could be something going on. Sunsetting eyes that look downward, similar to Perronne's phenomenon, bulging and fullness of the anterior fontanelle we talked about. It's sort of like a window into the brain and a pressure valve. Frontal bossing, distended head veins are also indicators of elevated ICPs. And then other things that we know already: increased sleepiness, vomiting, irritability, and not meeting developmental milestones. For older children's, headache, drowsiness, irritability, but also losing milestones is critical to pick up as well, and something that parents are very sensitive and attuned to, and definitely worth asking about. So these are some pictures of some of the signs of ICPs. We talked about sunsetting eyes. This is a bulging fontanelle in a child with achondroplasia, which can also have craniocervical and lumbar issues, and then the frontal bossing we talked about. So how do you assess the anterior fontanelle? It's important to palpate it upright in a quiet state. Crying or lying down can, because of gravity, can increase the fontanelle. So you want to assess this by running the fingers over the infant's skull where the frontal and parietal bones meet. You want to document the size of the fontanelle, and that can be soft, flat, full, or bulging. Sometimes when you're following these kids in the NICU, it's important to do serial examinations and document these things. So if there are any changes, the various teams know about them. And then commenting on the sutures, whether they're splayed or not, is also important. And even measuring the amount of splayed sutures can be important in terms of serial examinations. So the head circumference, I want to emphasize as well, this is really a vital sign in terms of evaluating pediatric patients. Normally at birth, it's around 35 centimeters. It subsequently increases in the first 3 months by 2 centimeters, and then tapers down from 1 centimeter to half a centimeter and so forth as a child grows. This was a paper out of University of Florida published in 2015, again, emphasizing the importance of head circumference measurements, even after the age of 3 years. They provided some examples on the chart on the left. You can see the head circumference measurement, and measuring and comparing them to the same-sex parent is important too, just to get some clues. This child had macrocephaly, but their parent also had a large size head consistent with familial macrocephaly, versus a child with a very large increasing head circumference that ended up having intracranial issues. So moving on, in terms of imaging studies in pediatric neurosurgery, all these imaging studies do have their place in pediatric neurosurgery. Ultrasound is used frequently as well. It really provides an opportunity to evaluate neonates for IVH and ventricular size, but more difficult to assess the posterior fossa. Serial ultrasounds, as we talked about, can evaluate for progression of ventriculomegaly. X-rays are important in terms of trauma evaluation, but also for cranial synostosis. CT scans for trauma. I tend to use CT scans if there are patients with hydrocephalus, complex cysts, and if there is an Ommaya reservoir or a catheter. I use intrathecal contrast to figure out if there are communications of the CSF pathways. MRIs are also important. Full MRIs, can involve conscious sedation or intubation by anesthesiology. So sometimes it can be challenging to get that. Fast MRIs, which are T2 sequence MRIs, are rapid and can be done without imaging studies, and also critical in terms of evaluating for hydrocephalus. Also, to keep in mind is in areas that are resource limited, some of these things can't be done, and so you have to rely on CT scans or ultrasound. So question 3, premature fusion of which cranial suture results in scaphocephaly?
All right, people feel free to answer in the chat box. One says C, 2 C's.
Yeah, so
3 C's.
Great.
Sagittal, a bunch of C's, Hasan.
That is
Absolutely
correct. So just talking about evaluation of head shape and going through some cases. So this is one of the more common things that one sees in clinic, in a pediatric neurosurgery clinic. So evaluating head shape, there are key history points to make, and that is, what was the head shape at birth? Was it abnormal at birth? And that could be a sign that of a premature fusion of the sutures, and we'll talk about that. Versus positional plagiocephaly, which is flattening on one side that develops over time due to head turn preference. It's important to ask about torticollis, which can contribute to the plagiocephaly, and then any family history of cranial synostosis. Physical exam findings, the cranial index or cephalic index we'll talk about, position of the ears and nose, forehead asymmetry and ridging along the cranial sutures can indicate premature fusion of sutures, and then imaging studies as well. So this is a diagram of a normal head shape, and essentially the pathology of a premature fusion of the suture prevents growth of the skull perpendicular to that suture, and so the skull ends up growing parallel to it. So on the left here, you see sagittal synostosis. These kids have a long shape or boat-shaped head, which is what scaphocephaly means. Metopic synostosis, they end up having something called trigonocephaly, which is more of a triangular forehead, and hypotelorism. Bicoronal synostosis, the kids end up having pterocephaly, which is a tower-like head. Unicoronal synostosis can lead to contralateral frontal bossing, as well as retraction of the orbit on the affected side. Lambdoid synostosis usually leads to the ear flattening on one side, and then the ear basically being pulled downwards. And then here you can see the positional plagiocephaly, which is just related to the head turn preference and laying down.
Hasan, can I have you just repeat which direction the skull grows and why the head becomes shaped as it does?
Yeah. So with synostosis, so if you look at this diagram here, this is a sagittal suture. So typically when the fusion of the suture occurs, it does not allow the bones to grow perpendicular to the suture. So in terms of sagittal synostosis, when it's fused, the bone ends up growing parallel to it. And that's typically relates to the growth potential of the suture itself.
Great, thanks. I just want to make sure that we repeated that so that
Absolutely.
people understood why the pathology occurs.
That's a great point. Thank you. So the cephalic index really is equivalent to the biparietal diameter divided by the occipital frontal diameter. And so typically the normal is 76 to 90%. Brachiocephaly, which is a flat head, is usually greater than 90%. And dolichocephaly, which is also a term for a long-shaped head, is less than 76%. Plagiocephaly, if you're following that, the diagonal difference can be critical in terms of classifying mild, moderate, and severe, and they have some treatment implications as well. So management of cranial synostosis is for another talk, really, but there's open cranial vault remodeling here versus endoscopic suturectomy, which is what I prefer, followed by helmet therapy. So just a couple cases. This is a boy, a 5-month-old boy with scaphocephaly confirmed with a CT scan of sagittal synostosis. This is his surgery. We ended up taking about 4 to 6 centimeters of the abnormal suture and biparietal bone off, doing these barrel stave osteotomies. This is his 6-month scan, and you can see the bone fills in over time, and this can even happen 12 months out of surgery. So a very good result. Typically endoscopic treatments are done up to 3 months of age. So this is another picture of a girl with a right unicoronal synostosis. You can see, we talked about the contralateral bossing, the retraction of the orbit on the affected side. The nose is also something that can help in terms of diagnosis. The tip of the nose I always find is deviated contralaterally, and that can be a tip as well. So here you can see the CT scan showing the synostosis and then surgery afterwards. The final case, a 4-month-old boy with multiple sutures that are fused, bicoronal and sagittal. You can see the abnormal head shape. Again, that's a clue to further assess with the CT scan. And then the surgery involves taking out the sutures, doing the barrel stave osteotomies, reshaping the forehead. And this is a child, I believe, 4 months post-op. So head shape really has improved. So plagiocephaly versus lambdoid synostosis. I find that plagiocephaly, really, it's a child that looks like a parallelogram. The ipsilateral ear is anterior displaced with frontal bossing and a flat head towards that side, versus lambdoid synostosis, where the ipsilateral ear that's affected is pushed down and there's contralateral frontal bossing. Something to take into consideration. Lambdoid synostosis is exceedingly rare, but it has been seen. So moving towards evaluation of head shape and macrocephaly, I'm just going to try to speed this up, try to keep on time. But again, history, developmental milestones, family history of macrocephaly is important. Physical exam findings, reviewing the head circumference charts and the growth charts we talked about, evaluating the fontanelle, and doing imaging studies if required. Macrocephaly, really the definition of that is when the head circumference is greater than 2 standard deviations above the mean age and sex for the child. And so this is a 7-month-old with rapidly increasing head circumference. You can see was at the 50th percentile initially, and then subsequently increased in size. A common, something that can be seen is benign enlargement of the extra-axial spaces, something called BESS. The precise cause is unknown, but it results from a functional obstruction of the arachnoid villi. It typically will resolve by 18 to 24 months of age. And so, it is really diagnosed by enlarged extra-axial spaces, usually abnormal if it exceeds about 8 millimeters in the first year of life. This is another scan done at 18 months of age, just showing how those spaces have decreased in size. And so this obviously does not require any surgical intervention. Another child, a 6-month-old, due to concerns for head circumference, really was at the 50th or so percentile, but rapidly went up. And this was very concerning. So we got imaging studies, and you can see here that there are a lot of fluid levels within the extra-axial spaces. This in and of itself is concerning for something called non-accidental trauma or child abuse. And so that's also important when evaluating kids. You can see them in clinic, in the ER. Non-accidental trauma workup, involves a skeletal survey to look for any fractures, a fundoscopic examination to look for any retinal hemorrhages. Ultimately, this child required surgery to evacuate these hematomas, and then this was the scan subsequently 4 months later with good resolution. Of course, we know, kids with tumors can also present differently than adults. This was a 12-month-old who ended up having a pilocytic astrocytoma, was seen with enlarging head circumference and months of ataxia and vomiting. And so it's also critical to note that, and also to do imaging of the whole neuroaxis when it comes to working up brain tumors in kids. So question number 4, when evaluating spinal cutaneous findings concerning for occult spinal dysraphism, all of the following are considered low-risk features except, and so that's A, midline sacral dimple, B, sacral dimple located within the gluteal crease, C, sacral dimple less than 5 millimeters, or D, duplicated sacral dimples located above the gluteal crease. So I guess looking at the chat, people are
feel
saying
free to
D,
answer
right?
in the chat section. I got an A.
Okay. Well, the correct answer is D, and we'll briefly talk about that. So sacral dimples are also something commonly seen in pediatric neurosurgery. And the question is whether this represents occult spinal dysraphism, things like tethered cords, fatty phylum, spinal lipomas. And so this is usually present, a sacral dimple, in 3 to 8% of children. Key points in history include asking about bowel bladder habits, family history. Physical exam findings include location of the dimple, size of the dimple, if there are any other neurological or orthopedic anomalies, and then subsequently, if there are concerning findings or high-risk features, ordering imaging studies, and if those are positive urodynamic studies to establish a baseline of bladder function. So low-risk features include dimples that are midline, less than 5 millimeters, that are located within the gluteal crease, and are not associated with any drainage. High-risk features are those really that are large, that are greater than 2.5 centimeters above the anus or above the gluteal crease, and if they're associated with other cutaneous manifestations, or if the bottom of the dimple cannot be seen. So this is a good article by Curtis Rosell, who's also a neurosurgeon in Alabama, published in, this is, I think, in the early 2000s, I believe. And so these are all examples here of abnormal dimples or findings that represent occult spinal dysraphism. You know, you have a dimple above the anus here, a caudal appendage above the gluteal crease. You have duplicated gluteal clefts here, an asymmetric dimple. This is normal, so you can see how the gluteal crease is being stretched, and this is within the gluteal crease, something that is not associated with spinal dysraphism. So something just to note. Ultrasound is key in terms of diagnosis, but can only really be done at age less than 3 months. And it's good to evaluate the where the conus is, not necessarily if there's fat or anything else, but typically the normal conus terminates at L2 in a child, and the phylum shouldn't be greater than 2 millimeters. So here you can see a normal position, and then on the right, you see that the conus is at L5. 2 patients that I operated on, a 13-month-old with sacral dimple and a history of imperforate anus who had a low-lying conus as well as a fatty phylum. Another example, an 18-month-old with a sacral dimple and a deviated gluteal crease with toe walking, as well as a syrinx. Again, this was sectioned in order to prevent, well, because of the syrinx, in order to prevent for future neurological issues. This was a 6-month-old girl with a sacral dimple and a cutaneous hemangioma. You can see that prompted further workup, and the imaging studies show a tract with a low-lying cord as well as fat within the spinal cord. And so lamnoplasties were done in terms of exposing this dermal sinus tract and then cutting the phylum where the fat was as well. Finally, question number 5. All of the following are risk factors for a growing skull fracture except. So we have age less than 5 with a cephalohematoma, bone diastasis of 4 millimeters or more, an underlying brain contusion, contrast MRI showing a dural tear, or presence of subarachnoid hemorrhage.
All right, looks like the most popular answer is mostly E's.
Yeah, that's great. You guys are absolutely right. So presence of subarachnoid hemorrhage. So I'll talk briefly about that. This was a case of mine, a 15-month-old girl who came to clinic with a pulsatile scalp mass that the parents noted. And, you know, again, differential scalp masses should be in your head. But, you know, and asking for questions about falls, and trauma, they noted that the child had fell from a couch 2 months prior, and the fall was so severe and her reaction was so severe that she went to a community ER, and she was doing well at the time, so they did not scan her. And so they came to my clinic with these imaging studies, and so you can see here that this is ended up being a growing skull fracture, which is also known as a leptomeningeal cyst. And really the pathophysiology behind this is it's a dural tear, and that results with herniation of the pia and the arachnoid through the tear, and that the CSF pulsations lead to bone erosion. And so this was a great article from Child Nervous System in 2016 that really looked at growing skull fractures and guidelines for diagnosis and surgical management. And they found in their patient population that the factors that we mentioned in the previous question are all risk factors and should prompt further imaging studies or even you know, surgical management. So this is that area exposed. You can see the bone was taken off, and the epidural substitute was sewn in place to close the defect. And then in order to cover this defect, we ended up splitting the bone and placing it back on with absorbable plates and screws at this age. So I'll end with this quick case. Again, this is something, you know, we always learn, you know, there's learning takes place not only in training, but also in practice as well. And so I wanted to share this case with you. This was a 12-year-old girl who had pretty severe skeletal dysplasia and progressive weakness over the years with difficulty writing. So much so that she couldn't really perform very well in school, and she was a straight A child. And so they had seen a neurosurgeon from another center who had recommended craniocervical, decompression and fusion. And then they also came to see me as well. I recommended the same thing. You can see on these scans, there's basilar invagination, there's an associated syrinx, but you can see that there's a lot of changes within the skull base, including this horizontal, essentially clivus. And so, they, after much, discussion with the family and giving anticipatory guidance, we planned for traction as well as a posterior fossa decompression and OC fusion to help her symptoms in the syrinx. But, when these imaging studies that I showed you were done probably 3 or 4 months prior to when she saw me, and when she saw me, I wanted to get the CT scan for pre-op planning, but I also went ahead and got a head CT scan just to see, what the ventricles look like. And to my surprise, she was developing hydrocephalus. And so, again, important to note when when the images have been done, whether repeat imaging should be done. This is oftentimes things that we do for Chiari's and syrinx and in terms of evaluation. And so, at least in my training, we always highlighted the importance of treating the hydrocephalus first. And so this was the pre-op MRI. And so I was, going back and forth of whether an ETV or a shunt should be placed. I know that the anatomy is difficult for an ETV, but I went ahead and tried the ETV. And so this is a video that shows sort of the anatomy, and I'll speed through this. So you can see that the horizontal nature of the anatomy and the basilar artery can be seen. And so, I tried to do this with all the different types of tools that we have, but eventually with some patience and persistence, we were able to make a hole within the floor. But towards the end, I noticed that, it's very redundant tissue. So, my fear was that this would scar off. And so we used the Nico cutter aspirator system to cut through that wall. And sort of the end result was what was the ostomy that we see here. And so this was a MRI from post-op day 1. 6 months later, her symptoms improved slowly. And then when I saw her with repeat imaging, her syrinx decreased in size. And I was, surprised. And this was a very interesting case for me. But, I'm also still concerned, obviously, about her craniocervical junction. But because she's doing so well, the family does not want any further surgery. But I still think that this is something that needs to be done. For the interest of time, I'll skip this case. But just to bring up the point of the CT with contrast, for me, I use this to confirm, in difficult cases, whether, communication between ventricles exist, or, if there's intracranial cysts, to see if a surgical intervention that we've done has helped. So that's important too. I want to end with this slide, resources for trainees. These 3 books are very, very good in terms of getting a basic fundamental knowledge of pediatric neurosurgery. I also recommend the ISPN Guide to Pediatric Neurosurgery, and this is the website here. It has great basic descriptions of neurosurgical pathology in terms of kids, something that I recommend reviewing as well. So I put this slide up in presentations that I give to other subspecialties. When in doubt, keep calm and call your friendly neurosurgery team. This is the pediatric neurosurgery team at UVA, with myself, John Jane Jr., and our nurse practitioner, Kelly O'Connell. I also want to really congratulate and thank Dr. Salman for these webinars that he's conducting. I had a chance to visit Karachi at the Karachi Spine conference right before the COVID pandemic, started. I was very, very thankful that I was able to, and hope that I'm able to visit sometime soon again as well. For those of you who have any questions, my email address is at the bottom left here. I'm happy to talk to you guys, answer any questions or concerns that you might have, and I appreciate your time. Thank you very much.
Okay,
Great.
that was a great talk. Yep.
If there are questions for Dr. Syed, you can put them in the chat. And let's see what we get. Looks like deafening silence.
Any questions, guys? What you could do is you can even raise your hands and we can switch on your mic and you can ask the question if you want. So Nurul and Iqbal says, thank you.
Thank
We're
you,
looking
guys.
for questions.
Questions? Bueller?
Everybody has answers to all the questions. Greg Trost, you could ask a question. You're an adult surgeon. You must have some questions.
I don't do any peds. I haven't seen a kid in clinic in 25 years.
So everybody says, excellent presentation, excellent, excellent, thank you.
Thank you, guys.
Okay, so one question is, ophthalmic papilledema, reliable and possible?
Yeah, so that's a great question. You know, my experience has been, you know, when shunt patients come or patients who have hydrocephalus that come to the ER, you know, typically if there's any question of high pressures in brain, we do get to check for papilledema, but it is not all present, and that's something to take into consideration. It's really the entire picture of the child and the clinical exam, the clinical symptoms in relation to the physical exam. So papilledema, obviously, if it's present, you know, there is elevated pressures, but it does not exclude the fact that there might be high ICPs.
Okay, so I think the
Looks
couple
like
of things.
Giovanni
wants to ask a question.
Has a question,
Yeah.
so.
Yeah, first of
Go on,
all,
Giovanni.
okay, first of all, congrats for the presentation. It was
Thank
very
you.
interesting to me. And I would like to provide with a question. I know maybe is a little bit far from your presentation, but I would like to know when you manage brain tumors in child. The management is completely different compared to adults, of course. And I would like to know if the use of functional MRI, especially the resting state, is a matter of, is something that you use in your practice, and if yes, what do you think about?
Yeah, so I think that's a great question too. You know, I do use functional MRIs. You know, typically, the pathology compared to adults, you know, doesn't necessarily require them. But you know, there are certain tumors that could be located, or cavernomas that can be located that need operations that I've personally done functional MRIs. But the age and the fact that a child has to be able to cooperate during that exam is critical. So, you know, it's difficult to do that in kids who are, 8, 9, 10, but, you know, children who are older in their teenage years, it's a lot easier. Relating to that subject, awake craniotomies, people have different, perspectives and experiences of that. I think in terms of awake craniotomies, you really have to have a good anesthesia team, but certainly there are people who do that at young ages as well.
Okay.
Okay, can I ask a question, please?
No.
Mr. Moderator, please, if you may allow.
Go ahead.
Okay, so you showed us craniosynostosis. So many times all these parents who are very concerned are asking us, what is the best time to operate in craniosynostosis of different types? Because
Right.
obviously people worry about closure of, cause these dura really getting stuck when you're operating, etc., and sinuses being ruptured and
Yeah.
chance of bleeding. So how do you manage your craniosynostosis?
So a great question. It depends really on your own surgical techniques and the team, your craniofacial team or craniosynostosis team. For my own experience, if a child is able to be seen and diagnosed by 3 months of age, I will operate on them via an endoscopic route, followed by cranial helmets. The cranial helmets have to be used, up to even 12 months after surgery. And so the parents really have to be committed to that because it has to be worn 23 hours a day. If a child is seen that older than 3 months, then sagittal synostosis, typically the surgery that we do here at UVA, I typically will do that between 4 and 6 months of age. Coronal synostosis that requires an open operation and not an endoscopic, typically older, 6 to 9 months of age. And similarly, the same thing with lambdoid synostosis. So I think it depends on two things. One, how your center treats these and what kind of techniques they offer, and two, when a child presents, at what age they present. But part of a job of a pediatric neurosurgeon is really explaining to the parents and giving anticipatory guidance. And so, oftentimes parents can be concerned about developmental delays and things like that. But the age range to correct cranial synostosis is very, very wide. So, if you don't get it at 3 months, or if the parents don't want an endoscopic approach, it is okay to wait to that period of time.
Brilliant.
Another question on here. Well, I mean, if people have a lot of questions for him, I think it's fine just to keep going in the.
We have enough time. We have loads of time. We have.
If there's more questions too, I'm happy to talk via email as well. And so I'm looking forward to looking at your cases as well, Dr. Trost.
Well,
so
my cases are.
We could do 3 more questions and then we can move. And then rest of the questions can be answered via email. Greg?
So this other question, I think, is probably says, what about posterior plagiocephaly? Do you perform surgery?
No, so posterior plagiocephaly is not a surgical condition. The incidence or prevalence of positional plagiocephaly increased, with the whole Back to Sleep campaign. And so how we treat this really is, it's all evidence-based, right? You look at the literature and, there's 2 ways really. One is the conservative treatment options, which include alternating the head position, bumping the child so that that they're laying on the contralateral side, tummy time. Those are all important things. And then there's also cranial helmets, helmet molding that's becoming increasingly popular as well. That can be done as well. Oftentimes, at least here, parents feel like they're doing something active, and so that's prescribed by some pediatricians and us as well. But they can be equally effective, essentially.
Do you use helmets in your practice?
We do, yeah.
Yeah.
But we sort of promote the conservative option. But a lot of times, as I said, parents want it or feel like it's doing something, and so we do it as well.
Yeah, our guys try to avoid it, but
yeah,
our grandson had posterior plagiocephaly from lying, and we basically just managed it conservatively. He doesn't have a perfect cosmetic look now, but looks pretty reasonable.
Yeah, the thing with helmets that I explained to parents is you have to wear it 23 hours a day, and then they have to come in every couple of weeks to have it adjusted. That's also an added, inconvenience, or can be an inconvenience. Sometimes the skin can be, affected because of the tightness of the helmet, and so on and so forth.
Great. So I think we'll probably move on. I have two things prepared. One is on C5 palsy, which we had some questions about last week, and the other one is about cervical disc arthroplasty. And the arthroplasty talk actually has cases embedded in it. The C5 palsy does too. So it's sort of up to you guys what you want to do. You want to put down chat, tell me which one you want to hear about, they're both about 10-minute.
You can do both, and then we can discuss. We have time. We have 35 minutes.
Alrighty, so let's do this. Let's do the arthroplasty one first, I think. All right. I don't have questions embedded in this, so
you can ask questions after every 5 slides. Whatever you teach, you ask questions.
Well, there'll be cases where questions can be answered to see if they're paying attention. So you guys see my screen or not?
Not yet. We can see you.
All right, let me share screen.
Imad, is Greg's screen share on?
Yes, sir. He is the co-host.
You're the co-host, man. You should be able to do this.
I'm hitting share.
Share screen.
Yeah, I hit it. Let's see what.
Can you?
What are you seeing? Just
Yeah, I'm just seeing what we've been seeing.
so you once you screen share, it automatically should take you onto your own screen.
Well, this is. Yeah, this is what I.
Imad, can you help?
Yes, sir. 1 second.
I'm on share.
Yeah, you have to open that window first, and then you have to go onto the Zoom, then share screen, then select the window that you have to show.
Right, that's what I've done. So I've got this talk. See if this one works better. See if that works.
Any luck?
Does not look like it.
Or you can email the talk to Imad and he can play it from here if you want. Or, you know,
Let me just.
whatever. Anybody has any questions for Hasan in the meantime? Let me go through the questions that were there before that we're not in the meantime.
Yeah, this is probably not gonna be functional.
Hopefully it should work. You want to send one of the presentation to Imad and we can switch it on from here?
Yeah, let's yeah, let me
So there's just email to Imad and
it'll take a little bit of work to get it there.
Oh.
Because they limited the size of our emails.
Oh.
I'm answering some of the questions just through the chat as well.
Okay. No, but it will be helpful for everybody. Endoscopic treatment of skeletal synostosis will give the same result as open.
Yeah, so I was just answering that. So I think that in my experience, the endoscopic approach is very nice in terms of results. If you look at the literature comparing open and endoscopic, you know, there are papers that describe equivalent results, and there are some that you know, say that there's a very you know, small chance of needing a reoperation in the future. But in my experience, I think it's a great technique.
What about ultrasound for optic nerve sheath diameter evaluation in hydrocephalus?
Yeah, that's a great question as well. I don't use that, you know, in our center, although we've talked with the ophthalmologist about that. You know, there are centers who are looking into that. including CHOP, which is a Children's Hospital in Philadelphia. And so I think we'll find more and more studies relating to that, and specifically for cranial synostosis as well.
Okay, then Adnan Tariq was asking, how would you manage a patient with Dandy Walker with hydrocephalus? Do you put in a shunt or in the cyst or what?
Yeah, you either shunt the cyst or the ventricles, and that is a very good question. Some people can be dogmatic about either the cyst or the ventricle. If you look at the textbooks, even the textbooks, say that there's no right or wrong answer. I would tend to shunt the ventricles or treat the hydrocephalus first, and then see what the results are.
It seems like Professor Trost has hit the jackpot or something. Yeah.
Boy,
looking good.
All right.
What happened there?
All right. So this is so with this whole COVID-19 issue, we started doing daily 1 hour professor hours with our residents. So this was that discussion. And it's about cervical disc arthroplasty. So there's about maybe 10 minutes of presentation, and then there are several cases, and the answer for all the cases is not arthroplasty. So they've all been de-identified, et cetera, et cetera. So we'll talk about cervical disc arthroplasty just by way of history. I've been doing cervical arthroplasties for about the last 15 or so years, and I was part of the original IDE studies looking at the Prestige ST, which was a stainless steel device affixed to the front of the spine with screws. That device is probably not used anymore. They've modified many of the devices that are out there. You'll get my bend on what is appropriate as far as indications go, and that's probably the most important part about this. Arthroplasty is not the answer for every patient, nor is fusion, in my mind, the answer for every patient. So as you can see, there's a wide variety of arthroplasties out there. And I put this together about this slide together about 2 years ago. It shows basically everything that's or most of the things that are out there. It's such a terrible idea that every company has developed their own arthroplasty device. We have to be clear about discussion of adjacent segment degeneration versus adjacent segment disease, because they're often confused when we talk about patients. Adjacent segment degeneration is simply a radiographic phenomenon. It just tells you that you have changes, bone, disc space height, etc., at the space next to a fusion or next to an arthroplasty. It has nothing to do with symptomatology. Symptomatology is the adjacent segment disease. And what that is just symptoms, whether it's numbness, a little bit of neck pain, a little bit of arm pain, and so forth. It does not necessarily correlate with operative intervention. So the Hillebrand study talked about the rate of adjacent segment disease being 2.8% per year for 10 years after arthroplasty or after fusions. And I think it's a little bit misleading because people often say, well, the rate of reoperation is 2.8% per year. That's not, in fact, the case. When they did their discussion of adjacent segment disease, it was essentially related to patients having some symptoms. Most of those resolved with physical therapy, and the rate of reoperation is actually only about 0.8 to 0.9%. So a small percentage of patients. So stop misquoting that study if you do. There have been several arguments for disc replacement, including adjacent segment disease, maintaining motion, relatively low success of fusion for treatment of multiple segments. Arthroplasties are approved for 2 levels here in the United States. I think going beyond that is probably not advisable. There's no graft site morbidity, at least here in the United States. Most people are using allograft and not using autograft any longer. No possibility for disease transmission, which can occur with allograft, although it is very rare. There's a decreased recuperation period in early and return to basically normal activities with arthroplasty compared to cervical fusions. At least from my perspective, with my fusion patients, I allow them to return to activity after I'm sure the fusion looks pretty reasonable. That typically will be 2 to 3 months, whereas my arthroplasty patients go back to their usual activities in a maximum of 2 to 3 weeks. And then there's no need for bracing. Most of us are not bracing single fusions. Two-level fusions, I still put in a collar for a month because most of the people I take care of can't follow directions. All right, so patient selection for arthroplasty versus fusion. And this is probably the most important slide in the whole talk. And we should talk about the need to have both treatments in your armamentarium. You should know when to do a fusion, when to do an arthroplasty. So single level disease, of course, is best for arthroplasty since they're only approved for 2 levels at the most. I've avoided 2-level arthroplasties for the most part. And that'll make sense when you see what my ideal patient looks like. Patients with multi-level disease tend to be better fusion candidates. People that have primarily anterior related pathology are better for arthroplasty. People that have both anterior and posterior disease tend to be better fusion patients. You should have motion at the disease level for an arthroplasty. If it doesn't move before you do surgery, it won't move after. And then all you've done is put an expensive device in that doesn't move and do what it's supposed to do. We have a surgeon here in town that puts an arthroplasty every single disc patient he has. And he said what happens is if it doesn't work or move, then it fuses. So he said the worst part about a failed arthroplasty is it ends up being a fusion. I think we should be a little bit smarter about that. Preserve disc space height my rule is at least 50% of the disc space height needs to be maintained. I don't put any distraction pins in either my ACDF patient or my arthroplasty patients. You're able to get enough room to work, and certainly with a preserved disc space, you have enough room to take out essentially what end up being disc herniations, which is what these arthroplasties are better for. No facet arthritis should be looked at when you do an arthroplasty. That's why we get plain films beforehand on every patient. People with a lot of facet arthritis tend not to move much. And then maintenance of sagittal balance is very important. Patients that are kyphotic will remain kyphotic. These are not alignment correcting devices. And that's why one of the most important things you should get pre-op is a standing lateral film. And then a variety of reasons to consider fusion would include osteoporosis, kyphosis, instability, tumor, trauma, infection for the most part. Arthroplasties were designed to or should be designed, I should say, to replicate physiologic kinematics. They should move as the normal spine moves. They should be durable. They should produce low wear, since a lot of the metal ions that are in the substances used to make devices can actually be toxic in a high enough volume. The good news with arthroplasty is they tend to produce a small amount of wear debris, as opposed to hips with a large surface area producing significant amounts of ions. There should be appropriate fixation. And this picture is the original Prestige device. The reason in the United States that it was used first was because stainless steel had been used in arthroplasties, such as hips and knees, et cetera, for a long period of time. So you didn't need to go through all the FDA clearance for the metal. So this is sort of a purposeful ploy to have the arthroplasty get on the market the fastest and gain the most market share. Currently, we don't. The fixation devices are primarily bony on growth. Most of the devices have some sort of rail that you can put into the vertebral body, and that's how it stays in place. They should be simple from a design standpoint, simple, but also the technique to put them in should be easy and reproducible. Here in the United States, you had to do a training session and be approved to put in arthroplasties. Metallurgy is also important. What the metal is does make a difference. These stainless steel devices that we originally used could not be imaged appropriately. You'd have to do a myelogram, post-myelogram CT after that. The current devices, a lot of them are titanium. The cobalt chrome ones also cast a significant amount of shadows when you image them, so they're not quite ideal to evaluate. Not quite ideal as far as looking at images afterwards. We all know the motions in the spine. And I think the most important thing to realize is that motions in the spine are coupled. When you flex and extend, you both translate forward and translate backward. It's not around a fixed point. And axial rotation is also coupled with lateral bending. This is opposite. The pattern is opposite of the lumbar spine. When you laterally bend to the left, the spinous processes in the lumbar spine will point to the left and point into the concavity of the curve. In the cervical spine, if you bend your head to the left, the spinous processes tend to rotate to the opposite direction. So lumbar motion and cervical motion are two different things. So motions are coupled. That's important to remember, both in cervical and lumbar, but they're coupled in a different pattern. There's two types of center rotation, and this is just a personal bias. They're fixed and variable, and my preference would be variable. With a fixed center rotation, you have a limited number of points where the spine will be loaded. Whereas if you have a variable one, you have an infinitely larger number of loading patterns. We know that from the literature, I'm gonna get rid of this one. This is from the literature, you can see that the centers of rotation for each of the discs are not a static point, which is what a fixed center rotation does for you. This is a dynamic point that changes with the pattern of flexion, extension, and rotation in the neck. In flexion extension, you can see that the centers of rotation tend to group around a centroid. These centroids tend to be located in the lower vertebrae of the spinal unit. So, for instance, for the C2-3 disc, the center of rotation is here in the upper part of the C2 body or C3 body. They tend to be in the upper upper third of the body and all vertebral body, and in the posterior third of the body. So whenever you design an arthroplasty, you'd like it to at least have the centers of rotation be fixed or be located in this area. And most of them are, and so most of them do a pretty good job with it. All right. We're going to get rid of those ones and talk about. So let's talk about my ideal patient for an arthroplasty. This is a young man who's in his mid-30s, and the assumption you have to make is that everybody's gone through conservative treatment in these cases, that they don't have any other option other than surgery. So beforehand, everybody should go through conservative treatment. There are obviously other options for cases like this. So this is a gentleman with a C6 radiculopathy on the left. You can see that he has a small, what looks like a smallish disc herniation. On this one, you can see here off to the left side that it is actually relatively large. He went through extensive conservative treatment. He works as a police officer and will not be allowed to return to work until he's basically back to normal duty. Now, I don't know. We can quickly run through the options with this if people want to. So Salman, I'm not sure how we can do that. I think that the three options that people would see for this would be ACDF, posterior amyotomy, or arthroplasty. And this is early in my arthroplasty career. So I can't see the chat at all. Does anybody have view of the chat? Let me see what's I don't have view of the chat. I'm sorry, guys. So, and I think that all of those were reasonably good options for a patient like this.
Sorry, so arthroplasty, ACDF, and foraminotomy are the three options suggested here on the chat.
Yeah.
So if you go down next to your screen share is the chat. If you click on that. Majority are saying ACDF.
Okay.
Dr. Saad, Nurullain, CG, Nur Malik, Khalif Abdullah, all saying ACDF. Usman
Right.
and Tala have said arthroplasty, and Ashfaq is talking about foraminotomy.
Yeah, so I actually think in this case they're all good. They're all good options. I avoided the posterior foraminotomy one because it's not an operation that I do commonly. This disc does extend to the other side or past the midline, so I was a little bit worried that would be a good option for him. I wanted to avoid ACDF in a man like this because he's a young guy with well-maintained disc space height. And I am a believer that there is increased rates of adjacent segment disease and reoperations in patients that have fusions. That, of course, wasn't borne out until the study started to have seven-year follow-up or longer. And you can see that at about 7 years, certainly the patients that have fusion have more surgery. So this patient was my ideal patient for arthroplasty in that he had well-maintained disc space height, normal sagittal alignment, and had the need to get back to work in a relatively rapid fashion. So this is what I did. And for some reason now my screen froze up. I'm gonna have to do it this way, it looks like. So let's see, we're gonna. All right, so let's see now. Okay, now make that. Okay, good. So he ended up with an arthroplasty. This was one of my early patients. And I think what you should take away from this picture is that the ideal sizing for an arthroplasty gets the arthroplasty to very close to the posterior end plate. The reason, or the posterior vertebral body. The reason for this being is that you'd like to have as much coverage of the end plate as possible. And with this particular device, this actually puts the center of rotation into the posterior inferior vertebral body, and it functions around many centers of rotation. The device should be placed midline. I think these things are very sensitive to satisfactory placement, and being as close to the midline is ideal. There are ways to do this. Sometimes, when you operate on patients, they do tend to move on the table. And I'll show you, I think it's the next case, how I exactly find my center and keep it there. I think the idea is that when you're doing these, that you mark your center position once in the beginning of the case and make sure that your images are stable. One of the things you always want to see on your plain film, and these are all done with fluoro, is that the spinous process is directly in the middle and sits equidistant from either pedicle. All right, and that's what you should strive for on your positioning. The other thing about positioning is you don't want to position your patients too lordotic or kyphotic. So you want a patient in a nice neutral position. This device actually shows you that also that motion is coupled. So when this patient flexes, so the center picture is just a standing lateral. The one on the left shows that when you flex, that the superior component moves forward on the inferior component, and when you extend, it actually moves back. So that shows biomechanically how this works. I told you that axial rotation is also coupled with lateral bending. So on the picture on the left, patient bends his head to the right, and you can see that the spinous processes tend to be off to the left, which is exactly what's supposed to happen. Lateral bend to the left, the spinous processes go off to the right. So that's perfect coupled motion. And this is not an advertisement for any particular arthroplasty, since they all tend to function this way. All right, so here's another patient, and I'm going to show you several images here, but this is a 61-year-old man who has what sounds like clinically either a C5 or a C6 radiculopathy. So hopefully as we play this, you'll see multiple these images. So we move side to side here. All right, and then so what you should notice here is that he mostly has disc disease at C5 or to C4-5. And I'll stop it when we get to the most important image. So here, 4-5, 3-4's got some disease on his axial images. He has primarily disease at C4-5. The C5-6 fragment actually looked pretty good. So 2-3, 3-4, 4-5, you can see lots of foraminal stenosis right there. And then when you go down to 5-6, it's okay, and 6-7 looks just fine. You'll also notice that his disc space is pretty degenerated here at 4-5. So once again, everybody, your choices in this. Tell me what you think the most appropriate treatment is. Whether this would be arthroplasty, ACDF, and Selman, I think you probably have the chat. I don't have the chat function I can see on this.
ACDF, one foraminotomy, 1 2-level ADF. Can you do anterior sequestrectomy, not destroying the whole disc, is the question.
Well, if you look in this, you can see that this is not just a simple, I'll get down to the disc space once, my little video. So that's how I record these, so people can see multiple images. Let's get down to the space itself. All right, so I think there's personally, I think just to consider something really limited may be a bad idea, since he does have central stenosis with this, that he has bilateral foraminal stenosis. So from my perspective, I don't think that this is a good unilateral approach for anything, because it does not address the entirety of the pathology. I think if you just did a limited disc removal on this patient, he may not have adequate relief of symptoms in the long run. This is one that I think would eventually fail. So in fact, he went on to have an ACDF. All right, so he was doing fine, and then developed some C7 radiculopathy. So he's had a previous 4-5 fusion that looks good, and now he has this disc herniation at C6-7. And this is a bit of an issue. And I think if we talk about options for this space, what do people think you would try to do with this? And trust me, conservative treatment all done. Really bothered by these symptoms. In fact, he's bothered enough he wants something done about him. So throw out some options for this, and you have to trust me.
Okay,
that
guys,
this is appropriate.
So you've got fusion there, and now you've developed an adjacent segment disease.
Not immediately adjacent. So he's at a 4-5 ACDF, and this is at 6-7.
Okay.
So
Is there an osteophyte there?
No, it's all soft disc herniation.
Okay,
It's
so
6-7.
there is arthroplasty by Gibran, a nerve block by Adnan, and then Saad Abdullah says ACDF. Gupta says ACDF with part corpectomy of C6. Rest of them are saying ACDF.
So single level ACDF or 2-level ACDF?
So it's a single.
Who wants to leave that C5-6 disc space alone between two fusions? Anybody?
Okay, anybody for hybrid procedure or anybody for fusion all the way? 2-level ACDF is Kola, and Rakib is saying ACDF. 2-level, 2-level.
Two-level ACDF. So people are falling down on the side of ACDF for the most part. Is what it sounds like, either single level or two level. And that was a bit of a dilemma for me, because I would hate. I personally didn't feel I wanted to do a fusion at C6-7 and then leave C5-6 alone, which has some, albeit relatively minor, degenerative changes in it. I'm sure, based upon his pattern, that would degenerate at some point. I proposed to him either two-level ACDF or a single-level arthroplasty. Gio, what do you think? Giovanni.
Giovanni, yeah, we need to unmute Giovanni, please. One second. We need to unmute. Imad, are you there?
Yes, sir. I'm muted.
Okay, the microphone is on. The microphone is on now. So
Good.
I would do ACDF.
Single level or two levels?
For the next one, for the new herniation.
Yes, the new one.
You already performed the CDF.
I did it C4-5. This is now at C6-7.
ACDF at this level.
Just the one level?
Yeah.
Okay, alrighty. So I think that would be, there'd be a lot of discussion about what the appropriate treatment was. So I'm not going to bother showing you the axial images because time is going to be a little bit short here. This was just my image to show you when I do an arthroplasty, how I position patients. So I get an AP film with a needle, essentially, just looking at the midline, and I want to make sure that patients are positioned midline when I do the arthroplasty, that they're not rotated one way or the other, and I adjust shoulders. I don't hyperextend them or hyperlordose them, and then from a lateral. All right, let's see.
So Gibran is saying that ACDF would further dispose to further adjacent segment disease. So arthroplasty is what we should do.
Yeah. So some reasons. So intraoperatively, which is what the next one's supposed to show. It didn't show it. Must have skipped it. So intraoperatively, what I do is I'll just do one AP film to identify the midline, one AP film right up front with the needle just inserted barely into the disc space of what I think the midline is. This is before I do all my longest coli dissection. So I identify the midline and mark it, actually put just a little divot with a drill in the vertebral body in the midline once I've determined where it's at. So this guy ended up having an arthroplasty at that level and has actually done pretty well with it. I don't want to show you because the next case is a two-level disaster. So this is a patient with two-level disease. I'm just going to show it to you just for kicks because we're going to end here. But two-level disease that underwent this and had really collapsed vertebrae ahead of time. And she actually did well for maybe six or 7 months, and then developed some neck pain, and maybe a little bit of numbness in her hands. She came to back to her primary care doc and had this. The operating surgeon said, "I have no idea what to do with this," and sent it down to me to look at. I think the question of this is, why did this happen? And I think this gets to my point earlier, is that I think there was probably some over distraction by trying to get these arthroplasties in and basically uncouple the facet joints. And so that's why I always say I never put distraction devices into a disc space when I'm doing an arthroplasty because I want to avoid this over distraction phenomena. So this lady, and I'm just going to run through this, had CT scans that actually show that the facet joints almost look like they're fused now posteriorly. So one side, and then as we move through, we get to the other side. You can see the arthroplasty completely dislocated in her case. So yeah, looks pretty bad. So it looks fused, doesn't it?
Yep.
Yeah. So they did flexion extension films on her, et cetera, and that didn't, they didn't really change. So in the operating room, to me, this was deciding whether to take out one arthroplasty, two arthroplasties, but really getting her back realigned was important. And this is her first film in the operating room. And you can see that she is still significantly subluxed on this image. So this is after, so we went posterior actually first to do a complete release, and you can see these little aggressive not even aggressive fascicectomies, but aggressive foraminotomies with a little laminectomy to try to get things to open up for. And then, so that's her posterior release. And then we went in the front and said, let's see what we can do. I was concerned about trying to be too aggressive because I wasn't so sure that the polyethylene core was stuck on here yet. So this is after turning her supine and putting a little distraction on her, and you can see that she actually has reduced to some degree. I then went and removed both arthroplasties. She didn't want either one of them. She was concerned that the second will do the same thing as the first, which it may very well do. So we did that, and then once they were out, so this is the space after the arthroplasties out. We did use some distraction pins in this particular case to try to distract her to allow us to release that, and then we took out the arthroplasty on the top, and she ends up with this from the front. And I felt uneasy enough that she had a significant amount of subluxation that we went and backed her up posteriorly too. So she's gone on and fused, but sometimes you have to be careful about what your indications are for this. So I think I'm going to stop there.
I was going to ask, do you have rights of these pictures? I've never seen such a horrible surgery before.
Do I have rights to these? I do have rights to these. This is, I've seen some devices have that particular device have more issues than others, but other people have had great success with that particular device. The talk is not designed to promote one arthroplasty over another. I just use what I use.
Okay, any questions, guys? We have to discuss this case. Giovanni, what would you have done? What do you think happened there?
Yeah, no, I don't know what happened. Maybe a trauma or something like this. So we don't know about it. Did you find out if the patient had the trauma?
No, there's absolutely nothing. She's a lady that does essentially a secretarial work.
Okay. So
yeah, no falls, no car accidents, nothing.
So trauma by a surgeon.
What's that?
Trauma by a surgeon.
Yeah, unfortunately, that is the case.
No, I don't think so. I mean, I don't find any reason for this. So maybe hyperextension. And
I think the issue was over distraction when the device was put in initially. That he was so convinced that he wanted to do an arthroplasty on her,
maybe, yeah.
And then basically a couple different sets.
I would like to ask you if you have experience, you know that I have with the hybrid solution.
With
hybrid solution.
Hybrid with
ACDF and the arthroplasty together.
Yeah, I have experience doing that. Yeah, I've done some. They work out pretty good. So when the arthroplasties first came out, they were only approved for single level. So I would, if people had 2-level disease, I would choose one for arthroplasty and one for fusion. So basically using my criteria that I talked about before, I would do arthroplasty on what looked like the most mobile level. I couldn't decide, whether it's the superior level or the inferior level. I think whatever one was the most amenable to the arthroplasty.
Yeah,
I have a patient with 3-level disease where the disc in the center has relatively normal disc space height and moves the level above and the level below. don't move and are really collapsed. And I would consider fusion on either side of an arthroplasty. So both sides of an arthroplasty in that case.
Yeah, I agree. I agree.
That one hasn't come. I think it's a good option.
Yeah,
And your results, Greg?
With my arthroplasties?
This hybrid.
Hybrid, I've only done about 3 or 4 of them, but they're fine. I've not reoperated on any of the arthroplasties, and in fact, I've not operated on the adjacent segment disease. And these are probably, the majority of those cases, even though there's not a lot of them, were probably 15 years ago.
Okay. All right. Good. Mark, can you show us? We have 5 minutes to go. Can you show us the results, the feedback from people about the webinar for today? Let's find out what Professor Trost taught us.
Yes, sir.
I don't teach you anything. If I touch it, be careful.
Yeah, I think it's we should have reminded you about or at least told you that the talk was today. I think it should have been done. So these are we're just getting some. So this is obviously we had discussed these questions, so these guys know the answer already. Despite that, some people managed to give wrong answers, which is interesting. Okay, question 2. Hasan, maybe you can take us through these questions, please.
So question 2, we talked about signs of elevated ICPs in pediatric patients, and the correct answer is all of the following except, and a flat anterior fontanelle is the right answer because it is not indicative of elevated ICPs.
Okay, can you go up, Ahmad? Ahmad has gone to sleep. Ahmad?
Fusion of the cranial suture which suture results in scaphocephaly? And the answer is premature fusion of the sagittal, which is C, which looks like the majority of people got.
Okay, and then 4th.
When evaluating spinal cutaneous findings concerning for spinal dysraphism, all of the following are considered low risk features except, and the correct answer is D, duplicated sacral dimples above the gluteal crease. It looks like the majority of people answered that. And then 5, all of the following are risk factors for growing skull fractures except, and the correct answer is presence of subarachnoid hemorrhage, which the majority of people also answered correctly.
So presenters feedback, can we go down? And we see about, oh, this is very good. 95% people were happy with your talk, excellent and good. The quality of content, and again, 98% people were happy that the content was very good. Keep going, Ahmad. Rating overall. So you've got 99%, 1% didn't like you for whatever reason. Okay, so this is excellent feedback. And would you like to hear this presenter again? And 100% said yes, they would like to hear you again.
Thank you, I really appreciate it.
Good job.
And now let's see Greg. Greg's one we have made ourselves, so you can imagine what's going to be. Okay, so this is Greg's, is it, Ahmad?
Yes, sir. It's correct.
Okay, so oh, it's the same thing, exactly the same thing. Okay, quality of evidence, very good. Excellent and good in 95%. The content, again, 95%. And overall, again, 95%. And let's go. Would you like to hear the same presenter again? One person did not like you, Professor Trost.
You know, you can't make everybody happy.
So brilliant. I think overall it was very, very good. Thank you, guys. It was wonderful having you all. Professor Trost, would you like to show some cases next week, next Sunday?
I can show some cases next week if you want.
Yeah, we can do something interesting. We can get Giovanni to show something as well next week, so we'll coordinate.
Can someone send me the link though before 2 minutes ahead of time?
Okay, we will. Tomorrow we have Professor Atul Goel talking about cavernous sinus surgery. I told you Henry messaged me a short while ago that he's booked a case for tomorrow, so he won't be there, but we'll have a couple of moderators for tomorrow. So and that's going to be interesting. And Imad, do we have anything else to show for, or is that the only, okay, you don't have things for Wednesday. Wednesday, we have actually Azam talking about endovascular options in neurosurgery on Wednesday. So we will be back, and yes, Greg, we will definitely coordinate with you, and we will make sure majority of the people felt that it was very, very good session. And we getting feedbacks from them, emails from them, and we have a WhatsApp group with their suggestions. So we continue to improve with that. It's wonderful.
Any particular kind of case you want to see next week?
What we will do is we will ask the people on the group what kind of cases they'd like to discuss.
Okay.
And
yeah, you just send
let
it to
you know
me
in a couple of days.
We can talk about deformity correction, which is what that other case was, but maybe fixed deformities, something like that.
Okay. All right. No problem. We'll do that.
Alrighty.
Brilliant. Thank you, Hasan, again. Giovanni, it was wonderful.
Much.
Everybody who connected, and we really enjoyed this.
Great seeing you all. Take care.
Great. Thanks, guys.
All right. Bye-bye.
Bye.
Take care.